Hi everyone. This is our presentation on malnutrition during pregnancy. It's presented by Abigail Wyndham, Ruby Amara, Thais Garcia, and Sarah Anderson. And we'd like to give a special thank you to our preceptor, Christina Badarocco, for helping us through this presentation. So just an overview of what we're going to be discussing. We're going to be going over nutritional needs during pregnancy, prenatal malnutrition, effects of prenatal malnutrition, interventions to meet mothers' nutritional needs, emotional impacts of food insecurity, and the sociocultural influences and risk factors that affect malnutrition during pregnancy. So to get started on nutritional needs during pregnancy, prenatal nutrition. Nutrition is obviously very important for everyone, but when you're pregnant, you're now eating for two. And you have to make sure what's being consumed will benefit not only you, but the fetus's growth and development as you go through your trimesters. So obviously nutrient needs are increased during pregnancy. You're going to have higher water and calorie intake. You're going to need to be eating more nutrient-dense foods, and vitamin and mineral supplementation is often recommended to ensure that you're getting all the nutrients that are required for healthy development. So good nutrition during pregnancy affects not only the baby, but also the mother, and can have long-term effects on her as well. So pregnant women should be making sure to consume an appropriate amount of food from various food groups. So like I said before, nutrition changes across pregnancy trimesters. So for a single fetus pregnancy, the first trimester typically has no additional calories that are needed. Come the second trimester, though, they recommend that the mother starts consuming 340 extra calories per day. And by the third trimester, that increases to 450 extra calories per day. So there are specific nutrients that you want to increase your intake of during pregnancy, and then there are specific nutrients that you want to decrease or completely cut out of your nutrient intake during your pregnancy. So here are 3 examples of nutrients that you want to increase the intake of during pregnancy. So iodine is really important and aids in the nervous system development of the fetus, and without it, or with a specific without the recommended amount, it leads to cretinism in the infant, which is a severe deficiency of thyroid hormones in the newborns. So the average person will be eating 150 micrograms a day, while a pregnant woman is going to need to eat 220 micrograms a day. So vitamin A is another fat-soluble vitamin that's very important for pregnant women to be consuming. It builds maternal and fetal retinol stores and prevents maternal anemia. So if there's a deficiency in this, the mother's at risk of developing night blindness, and there's the risk of the preterm birth of the fetus or death. So the average person eats about 700 micrograms of retinol active equivalents a day, because the body also does produce retinol. So, and then when you're pregnant, you're going to be needing to consume 770 micrograms of retinol activity equivalents a day. So then there's folate, which is important in aiding in DNA synthesis and amino acid formation in the infant. And it's very important during erythropoiesis, which is the production of red blood cells. And that is going to be rapidly increasing in a pregnant woman's body due to preparing for the birth of the child. So the average person is going to be eating 400 micrograms a day of folate, but a pregnant woman is going to need to be consuming around 600 micrograms a day. So of nutrients you want to completely avoid while pregnant, that is caffeine, sugar, and mercury. So you're going to want to be eating less than 200 milligrams of caffeine. Why? Caffeine makes your blood pressure and your heart rate spike, and that can lead to gestational hypertension, which is extremely dangerous because it can lead to preeclampsia and decreased blood flow in the fetus. Sugar is another issue that can lead to gestational diabetes. So you want to consume less than 30 grams of that. I know Ruby will be talking about that in her section. And finally, mercury. You don't want to consume any mercury. So when consuming seafood and fish during your pregnancy, you want to decrease the amount of white tuna you eat and completely cut out any shark or larger fish like that will have more risk of having mercury within them. So this is just an idea of the proper weight gain during pregnancy, considering the parts of the woman. But on the total weight gain you're going to be looking at is between 25 and 35 pounds. But those weight goals are going to be lower for women who are overweight before their pregnancy starts. So now that we're getting into malnutrition, just a general, what is malnutrition? So there are two forms, overnutrition and undernutrition. So overnutrition is the form of nutrient imbalance caused by an excessive intake of energy and nutrients. And on the other side of the spectrum, there's undernutrition, which is the form of nutrient imbalance caused by a lack of nutrient intake.
Hi everyone, my name is Ruby Amara, and we're going to be moving on to the complications of overnutrition. Obesity during pregnancy. Obesity and excess weight during pregnancy is associated with several pregnancy and childbirth complications such as high blood pressure, preeclampsia, preterm birth, and gestational diabetes. Obesity increases the risks of macrosomia, birth injury, cesarean birth, and birth defects, especially NTDs. Moving on to gestational diabetes mellitus. The pathophysiology of this condition is that insulin requirements physiologically increase during pregnancy due to increased maternal caloric intake, maternal weight gain, presence of placental hormones such as placental growth hormone and placental lactogen, and increased prolactin and growth hormone production. Maternal glucose is transported across the placenta to the fetus based on the concentration gradient of the maternal and fetal glucose levels. Later on in pregnancy, the fetus will divert an increased amount of maternal glucose across the gradient into the placenta. This leads to a decrease in maternal glucose levels. In order to maintain the concentration gradient, maternal hepatic glucose production increases as well as maternal insulin resistance. The beta cells of the maternal pancreas increase the secretion of insulin to prevent excessive delivery of glucose to the fetus. The management of gestational diabetes mellitus includes teaching patients how to self-monitor blood glucose levels, dietary modifications and nutritional monitoring, lifestyle changes, and maternal weight gain management. Some dietary interventions include collaborating with a diabetes educator or a dietitian to develop meal plans, instructing the patient to have 3 meals and 2 snacks a day, engaging in calorie-restricted diets, low glycemic index diets, the DASH diet, low carbohydrate diets, low unsaturated fat diets, high fiber diets, and soy-based diets. Emphasize a balanced diet with portion control, healthy fats, complex carbohydrates, and 20% protein. Maternal and fetal complications of this condition are that women with GDM are at an increased risk for development of preeclampsia and an increased need for a cesarean section delivery. Poor glycemic control throughout pregnancy can lead to a higher risk for preterm delivery, polyhydramnios, macrosomia, shoulder dystocia, admission to the NICU, neonatal respiratory distress syndrome, fetal hypoglycemia, and hyperbilirubinemia. Women diagnosed with GDM are at an increased risk of developing diabetes mellitus type 2 postpartum. Antepartum surveillance. For pregnant women requiring pharmacotherapy for persistent hyperglycemia, antepartum fetal testing should be initiated at 32 weeks gestation with a biophysical profile and a non-stress test. These tests are performed twice a week until delivery. Ultrasound examination should be performed once in the 3rd trimester to evaluate fetal growth. Fetal monitoring is based on glycemic control, the use of medication therapy, and presence of additional risk factors.
I'm going to talk about the effects of undernutrition on the maternal population. Causes of undernutrition are inadequate dietary intake and disease. This can be caused by food insecurity, inadequate care for women and children, insufficient health services, and unsanitary environments. Underlying issues are typically caused by conflict, inadequate education, poverty, gender inequality, inadequate infrastructure, and other basic issues. These basic causes can ultimately result in undernutrition in the maternal population. A risk of undernutrition in the mother is hyperemesis gravidarum, which is characterized by unusually acute nausea and vomiting. It's an extreme case of morning sickness that can result in fluid, electrolyte, and acid-base imbalances, which can therefore cause nutritional deficiencies, weight loss, and dehydration in the mother. Persistent vomiting is not only uncomfortable, but it can lead to a poor appetite and inadequate calorie intake. The leading causes of maternal mortality can result from undernutrition. Malnourished women can develop iron deficiency anemia, which can then cause life-threatening hemorrhage during delivery. Preeclampsia is a pregnancy complication characterized by high blood pressure. With women with inadequate calcium intake, the risk of preeclampsia is then greatly increased. Undernutrition in the infant can result in a reduced immune function. Exposure to pathogens in the environment can cause a prolonged illness. With a prolonged illness, infants will begin to lose their appetite. This then becomes a full circle and can greatly affect the infant's growth and development over time. The first 2 years of life are vital for infants' growth of the brain. A baby's brain grows dramatically during the first year of life, and therefore, poor nutrition during this time can result in underdevelopment of the brain. Long-term outcomes for the fetus are reduced human capital. So sometimes children will have a shorter stature and a lower lean body mass. Children tend to have poor cognitive skills and educational achievement and work capacity. Children also have a reduced fertility later in life. Continuing with long-term outcomes of the fetus, there is also an increased risk for later disease, such as hypertension, insulin resistance, and type 2 diabetes, reduced lung function and chronic renal and lung disease, and coronary heart disease.
Moving on to interventions to meet mothers' nutritional needs. Counseling with a registered dietitian is helpful for the patient to create a meal plan and exercise regimen. Referrals to oral nutritional supplements is helpful for a malnourished pregnant mom. These include sterile liquids, semi-solids, or powders, which provide macro and micronutrients. In addition, referrals to special supplemental nutritional program for women, infants, and children is another option. This program provides federal grants to states for supplemental foods, healthcare referrals, and nutritional education for low-income pregnant, breastfeeding, and non-breastfeeding postpartum women, and to infants and children up to age 5 who are found to be at nutritional risk.
Okay, so I'm going to talk about the behavioral, physical, sociocultural risk factors that all contribute to malnutrition for women during pregnancy. Some of these risk factors include low economic status, multiple pregnancies with a high frequency, rural residence, low maternal education, maternal depression, gestational diabetes, along with race and ethnicity. Some reasons that low-income communities experience higher rates of malnutrition during pregnancy include higher fertility rates due to unplanned pregnancies. This has to do with an increased amount of teen moms and single moms with higher incidence of pregnancy. Also, women in lower income households are at higher risk to smoke, have poorer dietary habits, and lower levels of education. Also, low-income communities are less likely to have resources needed to support these women struggling to meet dietary requirements. Another factor to consider is food insecurity due to decreased financial resources. Pregnant moms are more likely to spend their money nourishing their children first before spending that same money on themselves. When it comes to rural healthcare, there are significant health disparities between individuals living in rural settings compared to urban areas, including OBGYNs and prenatal healthcare. Families in these areas have less access to healthcare and lower rates of health insurance. This leads to lesser prenatal care appointments and follow-ups. There is also a correlation of higher rates of obesity in these neighborhoods, which can lead to overnutrition in pregnancy. And as you can tell from this picture, the darker areas, which are considered rural, are struggling with a shortage of healthcare professionals to provide for those individuals who are living there. I also wanted to touch on racial and ethnic contributions to health disparities when it comes to pregnancy. Gestational diabetes has a higher prevalence in communities of color, contributing to more difficult pregnancies. Other health conditions that minority groups experience an increased rate of is hypertension, obesity, and heart disease. These communities must be educated on management throughout their lives and throughout their community so that it can be controlled and not exacerbated during their pregnancies.
Alrighty, so to conclude on our entire presentation, our basic conclusions that we came across were that pregnant women have different nutritional needs that vary across the fetal development. Prenatal nutrition is vital for the health of both the mother and the fetus. Overnutrition in pregnancy can have long-term health effects on both the mother and the fetus. Gestational diabetes, mellitus, and obesity are two conditions that affect pregnancy. Maternal undernutrition is one of the leading causes of infant mortality without intervention. And risk factors of malnutrition during pregnancy are centered around access to healthcare and socioeconomic status. So with that, thank you very much for listening to our presentation. We hope you were able to take something from this today and enjoy the rest of the Malnutrition Awareness Fair.